Thank you for giving me a chance to speak. I'm actually really looking forward to getting some feedback and having a chance to contribute to this discussion. And what we're talking about today is care plans and team care arrangements and how we can collaborate better together. It would be really nice if my computer would actually, yes, there we go. Our learning objectives are to understand the requirements for care plans and team care arrangements, identify the role of allied health in collaborating in GP management plans and team care arrangements, and identify barriers and challenges to care planning. Sorry, I'm just, okay. So what is a GP management plan? It's basically an agreement between the patient and the GP and their team for how to manage a patient with one or more chronic medical conditions. It's a set of goals and plans for how to achieve the patient's optimum health. And they're meant to be proactive rather than reactive or ad hoc. And it encourages, part of a care plan also encourages the patient to take responsibility for their care. The process of building a plan is often a great opportunity for the GP and the patient to step back and look at what they're trying to manage and set goals that are relevant to the patient. So even though sometimes the care plan ends up having quite medicalised sounding goals, hopefully the discussion starts with what are you hoping to achieve? And often it'll be something like, I want to be able to go to the park with my grandchildren and play with them. And if you've got somebody who's got some disability, some breathlessness or some chest pain or decreased mobility, then that can be the motivating factor for getting them to participate in the suggested treatments. Who's eligible for a GP management plan? Sometimes I wonder when I get a message, you know, I want my 5 free, whatever, free. If the person, and it may have been a receptionist rather than the allied health provider, really understands what's involved in a care plan and who is eligible. So it's actually for people with chronic and complex medical conditions, expected to last at least 6 months or terminal. So some examples would be asthma or heart disease, cancer, chronic kidney disease, diabetes, and some musculoskeletal conditions, but not acute conditions that are expected to have resolved before the 6 months is up. Who is eligible? It's for patients in the community, private inpatients of a hospital who are being discharged, and this includes private inpatients who are residents of aged care facilities, but it's not for public inpatients of a hospital or care recipients in a residential aged care. But for those care recipients in a residential aged care facility, if the facility has done a care plan for the patient, there's an item number called 731 where the GP contributes to the care plan, and that can be used for those residents. What should be in a GP management plan? It should address the patient's healthcare needs, all of their problems and relevant conditions. So a patient can't have a care plan for their diabetes and a care plan for their COPD and a care plan for their low back pain. The care plan is for the patient and it should address all of their chronic health needs. It should have a list of management goals and actions for your patients. It should have a list of treatments and services that your patient will need in order to achieve their goals, and what the arrangements are for providing those treatments and services, and also arrangements to review the plan. Now, so far, that's the GP management plan, and we haven't necessarily involved a team. So there can be patients with chronic medical conditions who don't need a team. They can still have a management plan, but we just don't take it further to the team care arrangement. Who should prepare a GP management plan? It should be the patient's usual GP. That is, the medical practitioner or a medical practitioner in the same practice who has provided the majority of services to the patient in the last 12 months, or the medical practitioner who's likely to provide the majority of services in the following 12 months. So that might be if a patient goes to a GP and says, I'm changing GPs, I want you to be my GP into the future. And the GP uses the care planning procedure to actually help plan the care for that patient over the next 12 months. But what it shouldn't be is, oh, I couldn't get into my usual GP, so I went to a bulk billing GP down the road who I could walk in and get an appointment for, so they could do the paperwork, so I could get my 5 free sessions. That's not really what's intended for the process. So now we're getting on to team care arrangements, and I'm sure many of you are familiar with this piece of paper. And I really hope that that's not all you get from a patient that indicates that a team care arrangement in place. This is the Medicare form that you need to keep a hold of, I think, for 2 years. It doesn't have to be sent to Medicare, but it's part of the referral procedure. So what are the basics with a team care arrangement? They're only for people who have a GP management plan. So those people who have a chronic or terminal medical condition requiring treatment from ongoing treatment from a multidisciplinary team. So that's where the team care comes in. Or it can also be for an Aboriginal or Torres Strait Islander who's had a health assessment, an Aboriginal health assessment, and the identified a need for allied health services. That was new to me, and I want to say thank you to my exercise physiology colleague who taught me that when I was doing the health pathway for team care for exercise physiology referrals. The team can involve it has to involve the patient's GP, obviously, and at least 2 other collaborating healthcare providers, and only one of those collaborators can be another medical practitioner. It's usually a specialist medical practitioner. It's not really intended for it to be another GP unless that GP is bringing a different skill set to the management of the patient that the original GP is not providing. And all of the people involved in the team are for providing ongoing care. So it's not, I can't really name someone in a care plan who is just going to do an assessment and give me information and instructions on how to continue looking after the patient and then discharge the patient back to my care. So a one-off thing. It's really intended that all of the people on the team should be ongoing involvement in the patient's healthcare. What should be in a team care arrangement? It should have the treatment and service goals for the patient. It should have the treatment and service goals that the collaborating providers have agreed to give, actions that the patient needs to take, and review dates. Now, sometimes you'll see a document that has the GP management plan, and it's hard to tell if there's a team care arrangement as well, but often the management plan it also serves as a team care arrangement because you've named the collaborating providers and what the goals for each of those providers is trying to help the patient meet. So it doesn't have to be 2 different documents, but all of these components need to be in it for it to be considered a team care arrangement. Who can be part of the team? This is not an exhaustive list. There are some other healthcare providers that can be on the team. But you can see it's audiologists, chiropractors, diabetes educators, dietitians, exercise physiologists, mental health workers and mental health social workers, occupational therapists, osteopaths, pharmacists, physios, podiatrists, psychologists, registered nurses, speech pathologists, and others. And some of these people can have a very obvious involvement, and other times it can be a bit unsure about how people can contribute. So I'll give you an example of later on in one of the cases about the involvement of psychologists in care plans. We used to have dentists on the list, but dentists got taken off the list, although if a person has really bad dental health that's contributing to their poor diabetes control, for example, whilst the dentist won't get a Medicare rebate for providing care to, the patient won't get a Medicare rebate for the dentist's services. We can still name the dentist if we consider that they're an important part of the collaborative care for the patient. I just want to mention on the team, you can also put, for example, the patient's carer, if they're an essential part of the patient's care plan, but you wouldn't count them as one of the three collaborators, and obviously there's no Medicare rebate. So, but it's helpful sometimes to put the patient's carer on the plan if they really, to help describe between the patient and the carer what the roles are, and also to make it clear to the other people providing care that the carer is an essential part of this person's management. So the types of service, you can get up to 5 individual sessions of one-on-one treatment, and each of those treatments should be for a minimum of 20 minutes. And for type 2 diabetes, you can also get group allied health sessions, which involves one assessment for group services, and up to 8 group allied health services per year with either an exercise physiologist, diabetes education, or dietitians. And each of those services is meant to last for 60 minutes. So what are the referral requirements? It's actually meant to be the GP who initiates the referral and indicates what type of services need to be done. That Department of Health form that I showed you a few slides back needs to be completed by the GP and kept by the receiving health practitioner for 2 years. A copy of the plan should be provided to the patient, and another copy of the plan should be provided to the allied health provider. And some kind of collaboration should occur between the referring doctor and the receiving allied health provider. So what's collaboration? That's what it's all about, really, isn't it? This is communicating with other providers to discuss potential treatment or services they provide. It's meant to be two-way, and the Department of Health says preferably oral, but if not practicable, then in writing, including by exchange of faxes or emails. It should relate to the specific needs and circumstances of the patient, and the communication from the collaborating providers must include advice on treatment and management of the patient. And there should be the capacity for the allied health provider to provide input to the team care arrangement on the treatment and services they'll provide based on their understanding of the patient's needs. Well, this can be fun. I love to speak to my allied health colleagues about the patient, but I don't want to interrupt you when you're in the middle of a session of treating a patient. And I think probably there are GPs who it's very hard to interrupt us when we're in the middle of talking to a patient. So I think when you have people that you know and that you work with, it might be worthwhile scheduling a catch-up time when it's mutually convenient to have a chat about a patient. Often the GP will fax off the care plan and the referral form with a little, please sign if you're involved. And it should say, and please let me know if you want to make any changes to the plan. And I don't know how you feel about those letters, whether you feel like it's disrespectful, we're just asking for a sign off, or whether you feel that it's respectful of your time. But I think it can also be an invitation to ring and have a chat to the doctor, especially if you already know the patient. If you don't know the patient, it's a little harder. But Medicare's, I was reading the Department of Health guidelines again today to make sure I was on top of the details. And they were saying that an appointment to see the patient to assess them for the purposes of contributing to the plan is not actually claimable under the team care arrangement, because the team care arrangement can't be claimed by the GP until the collaboration has happened. So thanks, government. But that's, one of the restrictions we're living under. It's more helpful if it's an ongoing team care arrangement. You've already seen the patient for some sessions and it's come to the end of the first plan and the plan's coming up for review, and that's a really good opportunity to have a chat or a letter, a report. that helps set the goals and how the allied health provider feels that they contribute to the patient's care. So there we go. What are your reporting requirements? We're supposed to receive a report after the first and the last session in the period of time that the team care arrangement lasts for. Any investigations or tests that you have carried out, any treatment that you've provided, and any recommendations on how to manage the patient in the future. So what's the frequency of claims? The GP management plan is an item number 721, and it is a minimum of a 12-month anniversary, but it's actually recommended every 2 years. This can be challenging sometimes. If another GP who has seen the patient once or twice and has recognised they've got a chronic disease and has provided a care plan, then there's a limitation on me being able to claim that even though I'm their regular GP. And also I've had the situation where I've done a care plan for someone with diabetes and then 3 months later they've been diagnosed with stage 3 breast cancer with brain secondaries. And my claim for doing a new care plan under exceptional circumstances was rejected. So they really do stick us to the 12 months. The team care arrangement is usually renewed at the same time, so minimum of 12 months anniversary, but recommended every 2 years. But in between, we should be doing reviews, and we shouldn't be doing them any more often than 3 months, usually 6 months. But that's an opportunity to make sure the patient is working towards their goals, that they've actually started seeing one of the allied health providers on the team, and to reset goals if things have changed or they're getting better and you want to set new goals, or a new condition has come along and new goals need to be set. What happens with a new calendar year? You don't need a new care plan if the last care plan was prepared within the last 12 months, but you do need a new referral. The patient does need a new referral. The 5 allied health sessions either starts at the end of the original referral or the beginning of the new year. So if a patient has had, say, 3 sessions with the allied health provider and then in 2020, and then the 2 further sessions that were suggested in the original team care arrangement in 2020, they've had those 2 sessions in January and February. They need a new referral to reactivate, like they need a review of their plan, they need a new referral to reactivate their sessions, but they're only ever entitled to 5 sessions in any calendar year. So if they've had 2 sessions from the last care plan in January and February, they only have 3 sessions left for 2021, even with a review. Confused yet? So this has turned out to be quite a short talk, and I'm hoping that means that there'll be a chance for some Q&A. But I wanted to present a few case studies. The first one is an 83-year-old woman who was brought in to the podiatrist by the family to provide some foot care. The patient has no current care plan. They're no longer able to reach their toes and their nails are getting long. And I wonder what you think about whether they're eligible for a care plan and how you would communicate with the patient's GP. Does anyone want to feel brave enough to put some answers into the Q&A? I can't see anything there, Lauren, so I'm hoping you're keeping an eye on it.
Yeah, nothing's come through yet, Martina.
Disappointing. Okay, no one's typing away madly. So from this point of view, I don't think we know if this woman is, I can't tell you for sure if this woman is eligible for a care plan at this stage. You as a receiving podiatrist would have to take a medical history and see if they have a chronic complex medical condition. If it's just frailty, it's a bit hard. That's not it's not necessarily a diagnosis, although sarcopenia is. But I mean, not all 83-year-olds have chronic health conditions, but many do. Osteoporosis, diabetes, ischemic heart disease, those sorts of things are all eligible for care plans and could all mean that it's appropriate to have a team care arrangement involving a podiatrist. Yeah, thanks, Roger. Potentially complex, but on the surface not eligible. The other thing to bear in mind is that if the patient is not seeing any other allied healthcare provider or another specialist, it might be that it's entirely appropriate for the patient to receive podiatry. But if their GP is actually pretty gun at managing their chronic disease, so they're not seeing an endocrinologist for their osteoporosis and they're not seeing a cardiologist or a renal physician because the GP has got it all under control, then we're stretching things a little to actually get them eligible for a care plan. So it's something that, needs to be assessed by the GP. So you could start by saying, oh, do you see any other doctors other than your GP? Do you see a specialist about anything? Or do you see any other people for care, like a physio or something like that? And if you're starting to get a history that it sounds like they have got stuff going on, then it would be worthwhile talking to the GP about it. And I'm seeing another question there from Melinda, and I'm going to answer that in a minute, Melinda. Thanks for asking. So how would you communicate to the GP? Sometimes what happens to me is that I just get the family coming into a single appointment saying, oh, I just saw the podiatrist, sorry, podiatrists, and they said to come and get my 5 free sessions. And the patient doesn't understand at all what's involved in writing a care plan. It certainly takes longer than 15 minutes, unless I've just got a template, and I try not to do templated care plans, try to individualize them. So, it's probably might be better in this situation to write to the GP or pick up the phone and say, I'm seeing this person and I'm wondering if you think they're eligible for a care plan. And then saying not only, would you mind preparing it, but also saying to the GP at that stage how you would like to collaborate with the GP, what you think you can do to contribute to the patient's care, because that actually means that you're starting to do the process of the team care arrangement even before the GP's written the care plan. And that makes things run more smoothly for the patient in the long run. So I hope that's helpful. Next one. Isn't it funny how sometimes your computer just doesn't work? Here we go. We've got a 56-year-old male. He's got type 2 diabetes, hypertension, and ischemic heart disease, and also depression. And he's completed 10 psychological sessions under his mental health care plan. And my question in this is, can he get more? And this kind of goes into the question that Melinda was asking, which is, as a psychologist, I'm on occasion getting referral letter, TCA letter in conjunction with a mental health treatment plan. My understanding, this is just like getting any mental health treatment plan. And by signing, I'm just agreeing to be part of the team. Okay, so in my mind, there's two. So if a patient is seeing a psychologist for depression under a mental health treatment plan, it's against the intention of the GP management plan, chronic disease management process, to then add another 5 sessions with the psychologist to continue to meet the depression needs. and only be addressing the depression. So in my case, I wouldn't do that with the patient, because if I got audited, I don't think the Department of Human Services would think that I was meeting the intention of chronic disease management. But certainly, I mean, with this patient, if they've been seeing a psychologist for depression, it might be affecting the management of their other chronic diseases. They might have developed diabetes burnout and not be looking after their diabetes as well as they should. They might be having trouble getting motivated to participate in the rehab and the activity and the lifestyle changes that they need to be making in order to manage their ischemic heart disease. They might be having trouble with adjusting to their chronic disease condition, and that might be impacting on their quality of life. And so in that case, it may well be appropriate to assign 5 sessions through a GP management plan to a psychologist. But I'd have to very specifically make sure that it was clear that it wasn't necessarily for management of the depression, but it was actually for motivational interviewing and assistance with helping the patient adjust to their chronic disease diagnosis, and also helping the patient feel empowered to make the changes that they need to make so that they can look after themselves and work towards achieving their goals. So Melinda, I hope you find that helpful, and any other psychologists that are here. And if you don't, feel free to put another question up. It's a pity it's so big. It'd be nice to be having face-to-face chats about this. Okay, another common case in general practice, and one that causes a lot of questions on GP Facebook groups, is a 4-year-old child with their speech articulation behind. And do they qualify for a care plan? And I'm wondering if anyone's got anything to say about that, any thoughts or ideas that you want to pop into the Q&A. Okay, nothing written. For this patient, again, obviously you need more information, don't you? But if I have a child brought to me, can we have a referral to a speech therapist so we can get our 5 free sessions? Yeah, thanks, Carleen. Not eligible. And Roger for asking what's the cause of the speech delay, because they are both relevant questions. If it is just a straight speech articulation problem and the child is not behind in any other domain of development, and there's nobody else involved in their care, then unfortunately they don't meet the criteria. If on further examination you find that it's not just the articulation that's a problem, the child might also have some dyspraxia with, poor motor planning. You might be able to get more of a history of other developmental domains that are behind. And I think if there's 2 or more developmental domains that are behind, then it's actually appropriate to start going, well, this is complex and this needs further assessment. And so the GP might determine to involve the child health nurse in doing a deeper developmental assessment, perhaps get a paediatrician involved and start to address that speech problem, and maybe even involve an occupational therapist. And then all of a sudden we've got a bigger team than we were anticipating. And unfortunately, it might mean that it's not going to be 5 sessions with the speechy, because you might want 2 sessions for an OT, and the parents are going to start looking at how they're going to fund that as well. Again, it's like this was deliberately asked by me to make you think about where it might fit and where it might not fit. So that's my very simple talk. And there's plenty of room for questions. So just having a look at some of your questions, there's some really good questions. Thanks, Roger, for suggesting hearing issues for that child with speech issues. And yes, that's true, especially with an articulation. And you may have seen that one of the possibilities to involve someone in a team care arrangement is an audiologist. So it's probably very appropriate to get the child's hearing tested. And if the hearing is a problem and there's going to be ongoing involvement by the audiologist or an ENT specialist, now you're getting it multidisciplinary team. I'm going to address Melinda's question and then another question. And I'm hoping that the more we talk about things, there are more questions that come up. Melinda, I'm just reading it now. I just wanted to clarify that the clients aren't getting their sessions under the chronic disease management plan. They're paying full fee with rebates. I was of the understanding that signing the TCA, I was going to... Yeah, oh, sorry. Okay, so if you're not treating under the chronic disease management plan, but you're treating under the mental health treatment plan, it's still okay for you to sign to be part of the team care arrangement, but you shouldn't sign it until you actually have a look at the plan. So you shouldn't just be getting a letter saying, please sign here to say that I agree to be part of the team. You should be getting a chance to look at the care plan itself, and you have every right to ask the GP to provide a copy of the care plan. In fact, if I were you, I wouldn't be signing a letter without a copy. And this week I received communication from someone that I had sent a care plan to saying, what am I supposed to do? And it's clear to me that they haven't received a copy of the care plan, and I'm not quite sure what's gone wrong in my system and how that's happened. But I'm very glad that they didn't just sign it and send it back, but have said, you know, can we talk about this? Because I love the chance to collaborate. If you were to receive the care plan and you see that you are one of the only 3 people on the plan, I think that's pushing it. To be honest, I think there should be 3 people plus you. But if you're involved in the patient's management of their mental health stuff, and then there's 3 practitioners involved in the chronic disease management, then it's quite reasonable. You can have more than 3, but you shouldn't have less than 3. And the 3 people on the GP management plan should be managing the problems that are listed on the GP management plan. And I hope that's not making things too complicated. It may be. There is a question about, are there any other ways to communicate with GPs securely like Argus? I love this question, thank you. And one of the reasons GPs are holding on to their faxes is because because we're told that we shouldn't be using unencrypted email, and encrypted email is difficult to manage. The Argus is something that some GPs are using. We're more likely to use HealthLink because it's free to GPs. But Argus and HealthLink are supposed to be able to talk to each other. So if you have Argus, you might be able to contact the GP and find out what their EDI is, and then you should be able to send securely, which would be wonderful. We receive letters from specialists and pathology results securely, and I look forward to communicating securely. And I send letters to specialists that when I've got their HealthLink EDI, I send letters to specialists securely rather than faxing them, or sometimes I'll give them to the patient as well. Sometimes I'll just send them securely and say to the patient, ring, make your appointment, the letter's there already. And that helps people to triage. So yeah, I look forward to collaborating with allied health providers using Argus as well. Oh, I'm starting to see some more questions. This is great. Could I talk about aged care team care arrangement? I struggle with that, and so I'm not going to guarantee that the answer I give you is correct. I find that sometimes I'm asked to sign or to do a referral to allied health under a team care arrangement for a nursing home, and then when I say to them, I can't do that until I can bill a 732, so can I have a copy of the resident's care plan? It doesn't exist. And there isn't the capacity in Medicare for GPs to do a care plan for residents of aged care facilities. It's meant to be done by the facility. And so we can end up at a Mexican standoff. Caroline, can I ask you to put more details for your question so I can try and answer it a bit better? Janine, I've never been involved in a management plan to report back on outcomes. Oh, so I hope that you've received a copy of the care plan from the collaborating GP. And if you haven't, and you've just received that form, that Medicare form, and maybe a letter saying, please sign that you'll be involved in the team care arrangement, I think you need to push back a little bit and ask for a copy of the care plan. You are supposed to write a report after you've seen the patient for the first time to say something along the lines of, I agree with the goals on the care plan, and what I propose to do is this, and these are our goals of treatment. And then at the end of the prescribed course of care, you're also supposed to write back to the GP and say, this is what we've done, this is what we've achieved, this is what we'd like to do in the future. So I hope that helps. John's got a question. Apart from the required allied health provider letter that follows first and last, do GPs also like a telephone call update? Or do GPs find telephone calls overburdensome? I think that's a great question, John, but I also think grouping all GPs into one type is like grouping all allied health providers into one type. And sometimes even in my own practice of 12 doctors, I feel like it's trying to herd cats. So it's about trying to work out what works for you. I love to receive phone calls, but I don't take them when I'm in the middle of seeing a patient, unless it's from somewhere. It's really difficult because I want to receive calls from other health providers, but I want the patient in front of me to also feel like they're the most important person in the room. So if I can get a message or try and make a mutually agreeable time to chat, I'm very happy to chat. If you feel that you can adequately communicate by letter, and that there's nothing complex, or there's nothing that you don't want to put down in writing but you do want to communicate, a letter's probably just as good. And because it becomes part of the patient's medical record, which is good for us to be able to demonstrate that communication is happening. Having said that, if I receive from a call from another health provider with my patients, I will document that call in the patient's file. But sometimes there are things about the patient that you want to say that you don't want to have in black and white. You just want to ask questions, or something's not right. You've got a gut feeling and you want to see if the GP's got any insight into it, and that's definitely time for a phone call. Please call. The more we collaborate, the better outcomes we have for our patients. And going further, John, how concise should a patient update letter to a GP be? Less than a page. And most GPs prefer dot points, I'm told. I'm quite happy to read a narrative. I have a psychiatrist that sends me 5-page letters. I save them for when I've got time to read them. I don't read them immediately. So that's a bit too long. But for a psychiatrist, it's necessary. But for most allied health providers, I think if you can fit it onto a page and dot points, it doesn't have to be too detailed unless you feel that it's necessary. And having said that, I've read reports from OTs or speech therapists, for example, where their assessment of the patient has been extensive, and it's actually really helpful for me to have the details of their assessment, because down the track I may need to use that evidence to support applications for increased needs in school or something like that. So if you've done an extensive assessment with a child, for example, please send me the details, because I am going to find that helpful, even if I do need to set aside time to read it. But then once you've done that and you've set a plan, you probably don't need to send as extensive information back to the GP as things go on. Janine, I'm not quite sure what kind of allied health provider you are. The question is, I've never been involved in a GP management plan. Is there a form to complete to report on the outcomes? No, there isn't a form to complete to report on the outcomes of interventions. It's just a letter to the doctor. Dear doctor, I've seen Mrs. So-and-so for their 3 sessions allocated under their care plan. And the goals that were set were this, and this is what we've done, and this is what I'd like to be able to do in the future would be appropriate. Going on to Carleen, aged care have to have a care plan to meet accreditation requirements. Yes, I know they have to, but it's really shocking to me when I ask for a copy of the care plan that it hasn't been done. And I think that's probably a reflection of how the overwhelming burden of paperwork that we all struggle with, yourselves, myself, and aged care providers. It just never seems to go away. And I think there's often the intention, but, you know, if they got audited, they'd find themselves in trouble, some of these aged care places. So, but it makes it very difficult. If they want me to sign off, then there has to be a care plan. Maybe that can be a trigger for them to develop one. And I'm really sorry, Carleen, I'm not sure of the actual procedure either, because I've always got stuck at that point where I've said, can I please have a copy of the care plan? Mariam, I have a problem with the doctors telling patients the sessions are free. Oh my goodness, that's terrible. They've had another referral to another allied health discipline and the patient didn't tell you, so you were left out of pocket. I absolutely agree with you. I don't tell the patients that the sessions are free. I'm actually really careful with my language because I talk to the patient about if this gives you 5 sessions with an allied health provider where you get a rebate from Medicare for some of the cost of the session, which otherwise you wouldn't get, and you would be paying the whole amount out of your pocket. So if you have, all I can suggest is that you feed back the issue of free to the doctor who is telling the patient that. I think you also have to bear in mind that if the patient tells you that the doctor said it was free, we all hear, the patients often tell us things that they would like to be the truth. Or maybe their friend at Bowls told them it was for free. And they got confused. So it's possible that the doctor didn't say that and the patient misunderstood. But I absolutely agree that we should not be saying this is free. Medicare's not ever intended to cover 100% of medical costs. And wouldn't I love to be not bulk billing all of the pensioners and healthcare card holders that I see, but I certainly don't expect you to. So I agree, it's not a fair system. And Carleen, yes, I think the patient, the CMA, but there has to be a care plan done by the nursing home, and then the GP can contribute to the already existing care plan, and then we can do a team care arrangement. John, how would I suggest that allied health providers organise meet and greet with GPs in their area? Is there a common etiquette when meeting a GP? Do medical practices offer a lunch and learn for GPs? If so, I think that's a really great question. It's funny, my practice doesn't see drug reps anymore, so we don't have lunch and learn done by drug reps. Some of our doctors will avoid the lunchroom if there is somebody in the lunchroom giving a talk, because they like their lunch to be just about having a break, having a mental break. But you can certainly ring the practice and introduce yourself and offer to come and give a talk and see what they have to say. You don't have to bring lunch. It's appreciated if you do, but you don't have to bring lunch because we don't expect people to have the money to be doing that. Some specialists do, and we let them bring lunch for us. But yeah, I think that probably the easiest way to do it is if you're receiving referrals from a GP practice already and you haven't met the person face to face. It would be really nice just to say, I'd love to meet you face to face and see if there's anything more we can be doing to support each other. And that builds that relationship. But of course, you're probably also wanting to build your referral base, which means doing a bit of a cold call. And all I can suggest is that you phone the practice manager and see if the practice has the capacity to do that sort of thing. Certainly a lot of general practices have informal or formal clinical meetings, and it may well be appropriate for you to offer to do a presentation on something that you think would be relevant. So good luck with that. That's awesome. So that's all the questions I've got so far, and it looks like we're doing quite well for time. I'm happy to answer any other questions or take any other feedback from people. No? Awesome. That's great. Thank you. Let me see if I can get that. So thank you very much. Oh, something coming in. This is very helpful, Martina. Helpful if there's a webinar on how GPs and psychologists navigate the referrals. Yes, Sally. That's a good suggestion, and I'm sure that will be taken on board by Lauren. Thanks, John. And there's a question that says when it comes to imaging, and if you want to type really fast and fill that question in, I'd be happy to try and address it for you. Otherwise, you've got my, good. Are GPs happy to receive an imaging referral? Well, it depends. It's up to the, if, I see where you're coming from. The question is, are GPs happy to receive a request to provide an imaging referral from an allied health provider because the rebate's better with a GP referral? And it's a yes and no. If the GP feels that the imaging is indicated, then I'd certainly be happy to provide an imaging referral, but not in all circumstances. And bearing in mind that GPs have a lot of restrictions and expectations on choosing wisely and not over-investigating. And the other thing is, if I order a test, then I'm responsible for what happens with the results. And so I would expect to see the patient back after they've had their imaging to explain it from my point of view before they go to see the allied health provider who really wanted the test, and to have the allied health provider's opinion on what's going on. So I know that's a bit controversial, but if it's my name on the order test, I'm responsible for the results, and I need to make that clear to the patient. And yes, of course, it needs to be relevant. I hope you found that answer helpful. My email address is on the slide. Feel free to contact me if you have any other further questions or for any reason. That's my work email, but I can also use that email for anything to do with health pathways. I haven't told you about health pathways. I've presented on that in the past. But if you are interested in Health Pathways, which is an online portal it's designed for GPs, but it can be used by other health providers as well. It helps determine how to assess and manage patients with certain conditions. And one of the strengths of Health Pathways is that it helps you also identify the local referral places and procedures to help get further care for the patient. So just to use an example, diabetes, it's, would show for newly diagnosed diabetic what we need to do to assess them, what tests we need to do, how to start management, and under what circumstances we should refer them to an endocrinologist, and then who are the local endocrinologists, where are the local endocrinology clinics, how do I get a diabetic with a bad foot into the high-risk foot clinic, all of that sort of thing. So it really helps GPs who may not know, because none of us are specialists in, like experts in everything. helps us find our local resources for the patients. So if you want access to Health Pathways as a member of the PHN, you can contact the Health Pathways team through the PHN website and they'll send you a login so that you can have a look and use the service.